Good afternoon, everyone, and welcome. Thank you for joining us today for the Innovation in Prostate Surgery webinar. It is great to have you with us this afternoon. I'm Mariana from Health Innovation Oxford and Thames Valley. We have a really exciting agenda ahead, and to get us started, I'm delighted to introduce our chair for this afternoon's session, Mr. Tom Leslie. Tom is a consultant urological surgeon at Oxford University Hospital's NHS Foundation Trust and also serves as the Urology Clinical Advisory Group Lead for the Thames Valley Cancer Alliance. It is my pleasure now to hand over to Tom to begin the session. Tom.
Thank you, Mariana. That's very kind of you. So there's an exciting opportunity for us to talk about some of the, in particular, surgical innovations around prostate cancer. But to give the best overview of this, we've got the Nuffield Professor of Surgery from Oxford, who's led the urology department and in particular the prostate cancer research in Oxford and nationally and probably internationally, Freddie Hamdy. So I'm going to hand over to Freddie first to just give an overview of how our program has developed over the years and why we're giving these talks today.
Thank you very much, Tom. Can I just check you can hear me okay?
I can.
Yeah. Okay, great. So firstly, congratulations to you and Mariana for putting this together. I think it's a great opportunity to talk about some of the innovations and some of the research that we've been doing here in Oxford. I would like to acknowledge that the work over the past 25 years or so has been driven by a very large team of multidisciplinary people ranging from basic scientists through to translational researchers, clinical researchers, and that encompasses not just university staff, but also a lot of NHS staff. And without that diversity in that team, it just would not be possible to do the work. And our work obviously extends outside Oxford and involves many other centres in the UK and internationally. So as far as prostate cancer is concerned, basically our aim for the last 2 or 3 decades has been to address the most important unmet needs in the management of what is the most common malignancy in men in the Western world, in the UK, with many deaths every year. But there are 2 particular spaces that we're interested in prostate cancer. The first is the pre-diagnostic space, and this has everything to do with a simple question: should we screen for prostate cancer? And what is the best diagnostic pathway? And there are 3 exemplars of some of the work that we've done. A very large seminal study called CAP that we've been doing for the past 25 years, which is the largest screening study in the world, which to date has shown that the harms of doing early detection and early screening, population screening, outweigh the benefits. But the work continues, and there is more work which is coming out from the UK, the Transform trial in particular. Biomarkers, we've been working on a lot of different biomarkers, and one exemplar is the 4-callicrene, which is the different forms of the isotopes of PSA, which have shown that you can reduce the number of biopsies and reduce the detection of over-detection of indolent disease and increase the detection of significant disease. And then what is the best approach to prostate biopsy? And you will hear more about this in a minute. And the second very important space, which we really are focused on considerably, is the post-diagnostic space. So once you find prostate cancer, what do you do with it? And we know that currently the majority of prostate cancers which are being detected actually don't need to be detected, because many of them follow an indolent course. And the exemplars for this are, again, a study we've been running for 25 years called PROTECT trial, which compared in screen-detected men surgery, radiotherapy, and active surveillance. And so far, up to 15 years follow-up in clinically localized disease, low and intermediate risk. We have not found any survival benefit to treating, but treatment does reduce the rates of metastasis, and we use this in our clinical practice every day. And then how do we improve the surgical outcomes when we do a radical prostatectomy? And there's been a shift over the years where when I was training 30 years ago or longer, we used to treat any prostate cancer, and we were not really conscious of the fact that we could stratify the cancer depending on risk categories. As time went on, we are now treating less and less low-risk disease, and we're treating more and more high-risk disease, more and more locally advanced disease. And in order to get what we call the perfect trifecta, then we need to improve our surgical excision, and you will hear more about that using the next generation, the next innovation in surgery, and that is to be able to see what we resect, and that's image-guided surgery using molecular targets. So Hamdy will be talking about that. Then how do we reduce the side effects of treatments? And that's both radiotherapy and surgery. And Tom, you'll be speaking about our efforts to evaluate focal therapy in unilateral prostate cancer. And finally, the most important thing in the post-diagnostic space, once you find prostate cancer, is to understand what is likely to happen to the disease in the long term, and whether the disease needs to be treated and how it should be treated. So we believe that there are at least 3 phenotypes of prostate cancer. There is the cancers that never progress, never metastasize. They should not even be detected. There are the cancers which will metastasize, but will not necessarily kill the patient. And we've seen in studies like PROTECT, patients surviving 20 years or longer with metastatic disease. And then there is a small number of men who have lethal disease, so they will die of prostate cancer. And the best analogy of what we're trying to do is, if you think of planes, when a plane crashes, the first thing that all the investigators do is they go out fishing for the black box. Black box is the flight recorder, because the black box has all the information of why the plane has crashed. I don't know why we call it black box, because when I looked it up, it's actually a red box. But that's not the point. So what we are trying to do is that in every patient who dies of prostate cancer, he has in his biomaterial, whether it's blood products or tissue, he has this little black box which tells us why he has died. And we are therefore using all the technologies that we can handle and get access to, and that includes very comprehensive. So we're trying to align the phenotype and using 3-dimensional pathology, for example, digital pathology, which Sandy will explain to you, the genotype, so what is the DNA composition, the genomics, the spatial composition of the tumors in individuals, aligning this with imaging using artificial intelligence to try and come up with algorithms which will tell us what is likely to be in that black box, so that we can improve the outcomes for these patients, and most importantly, avoid over-treating patients, giving them morbidities from the treatment. So you're going to see during this seminar snippets of what we're doing. Very, very grateful to all the speakers, grateful to Tom for giving us, and he's been a major contributor, not the least. So Tom, thank you, and I hope everybody enjoys the seminar, and I think we're going to take questions at the end. So thank you, Tom.
Thank you, Freddie, and you know your leadership and kind of both locally and around the world has driven this area forward, and it's continues to be exciting. There's so many unmet questions and lots of trials looking to answer them. And I think in small part we've been able to lead and be part of other people's trials around the country doing this. So it's wonderful. Now, the Professor Richard Bryant, who's one of our colleagues in Oxford and is the clinical lead at Oxford as well, unfortunately has been called away to an emergency, so he's unable to talk. So I'm going to present the Translate trial on his behalf. Richard was the chief investigator, and together with Alistair Lamb, and they led this, I think, landmark trial in the UK, which is going to influence practice throughout the world, and was recently published in the Lancet, which we'll see in a second, and has been presented both in the EAU and AUA meetings this spring, making quite a splash. I was a principal investigator in Milton Keynes, where I work as well. So I have been part of this trial, as have Aaron and Freddie, helping to recruit patients. So the Translate trial, yes, thank you, Mariana, that's fantastic. So the Translate trial was to look at the big question of how do we biopsy people. The prostate biopsy is probably the third step perhaps in the patient's pathway towards being diagnosed. They're seen by their local doctor. They have a PSA test. They have a digital rectal examination, and then pretty much everybody now has an MRI scan. And if an MRI scan has some level of suspicion on it, a patient is going to be offered a prostate biopsy. And until really quite recently, there was one fairly standard approach, which was a transrectal prostate biopsy. But increasingly, which perhaps goes to the next slide, increasingly the mechanism of doing the biopsy has developed to become a transperineal biopsy. And many guidelines now advocate this, and it's an alternative mechanism for getting the prostate tissue to make the diagnosis. However, the change in practice has probably gone ahead of any proper evidence, and so Richard and Alistair, along with the colleagues around the country, sat down and said, how are we going to answer this question properly? There have been other RCTs designed and published. They've all had varying primary outcomes, either infection or sometimes diagnosis, and they've not necessarily been powered to answer the question appropriately, but they've been published, and you can see PRO-PC, PREVENT and PERFECT have all been published in the last 12 months. But there remained uncertainty regarding cancer detection, infection rates, other complications, importantly cost effectiveness of LATP, which is short for local anesthetic transperineal biopsy, versus TRUS, which means TRUS is short for transrectal ultrasound guided biopsy of the prostate. Next slide, please. So we designed a trial to try. It was meant a pragmatic trial to try and to be using centres around the UK in an NHS setting, real life practice, and over 1,122 patients were randomised 1-to-1 to either have a local anaesthetic transperineal biopsy or a local anaesthetic transrectal ultrasound guided biopsy. The primary outcome was detection of grade group 2 or greater prostate cancer. Just to be clear, for those of you who aren't so familiar with prostate cancer terminology, grade group 1 is essentially Gleason 3 + 3 = 6, which is very low risk prostate cancer. Grade group 2 is Gleason 3 + 4 = 7. Grade group 3 is Gleason 4 + 3 = 7, and so on upwards to grade group 5, which is the equivalent of Gleason 10, which is very aggressive. So it's generally accepted from data from the PROMISE trial in particular that grade group 1 cancer would be best left undetected. But anything with grade group 2 and higher, we would like to know about it, because then the patient can be properly informed about a treatment choice. So we wanted to know if one of these treatment biopsy modalities was going to be better at detecting clinically significant prostate cancer. Important secondary outcomes were infections or other hospital-related problems, bleeding, urinary retention, pain, how well the patients tolerated these procedures, and importantly, within the National Health Service and any other health system in the world, whether it's cost effective and really whether this is just consultants, clinicians driving it forward without any thought to the cost that it might have for both the patient and, importantly, a health system. Next slide, please. So the inclusion criteria were really any men over 18 with an elevated PSA or an abnormal digital rectal examination who had had an appropriate pre-biopsy MRI. We weren't looking at men who'd had lots of biopsies before or who had what looked like a large amount of prostate cancer, which was clear without even having to do a biopsy, so a high PSA or really sinister looking MRI. And there are some people who are can't have a biopsy by one route or another, so they were obviously not included. We tried, and I was part of this trial design discussion, and we went back and forth a lot over what was the best thing to try. We wanted it to be as equal as possible. So with LATP, we were not giving antibiotics. They were having skin prep, but the biopsy regime was a systematic 12 biopsies, 6 from either side, and 3 or 4 biopsies from the target, cognitive targeting. And similarly with the trust biopsy, they would have the standard of care in their hospital, so some antibiotics pre and post the biopsy, but taking a very similar style of biopsies. It's a slightly different pattern, but 12 systematic biopsies in total, plus some cognitive targeted biopsies. For those of you who aren't familiar with the technique, you can see the diagram on the right of the slide here, where transrectal effectively means the biopsies go through the rectum up into the prostate, but can access slightly different parts of the prostate. Transperineal, the top picture, the needle goes through the skin and into the prostate, both with an ultrasound guidance. So the principles are slightly different, but in practice they're just targeting different ways of targeting the prostate through a different angle. Next slide, please. Next slide, please. So in terms of the patients recruited, it was a recruitment took a little, kind of like any of these randomized trials, it kind of built up momentum, but it was not a hard trial to recruit into. 97% of the patients accepted their allocated biopsy, so we were able to have a relatively evenly matched group of patients who had similar demographics, a mean PSA of around 7, so it'd be a 8.8. The same age profile, really very well matched. A lot of the patients were white and British. That just demonstrated the centers that were involved. Next slide, please. And the primary outcome was that local anesthetic transperineal biopsy, LATP, had a 5.7% better detection of clinically significant disease, grade group 2 or higher, than with trust biopsy. And this was, as you can perhaps see from the slightly more granular data there, so effectively it was 60% of men in LATP versus 54.4% of men in trust. It was an intention to treat protocol, so even if you applied the protocol, any protocol deviations, it was the same. So clinically significant either way. Next slide, please. Infections always another big question mark around transrectal versus LATP. The principle being that obviously transrectal goes through a more a less clean, inverted commas, area, and again, as expected, the infection rate was slightly lower in LATP. Overall, only 6 men overall had post-op infections versus 13 in trust biopsies, which is still pretty low considering the over 1,000 men we were looking after. If you extended that to slightly different a different remit. So that's infections causing hospitalization, but symptoms and signs plus minus hospitalization, i.e. men who may have had some antibiotics from the GP or reported symptoms in keeping with an infection. It got closer at that point. Overall, 113 in the LATP arm and 120 in the truss arm. It's interesting, 4 months after a biopsy, I'm not sure that either of the biopsies can necessarily be blamed for much of the symptoms people are having, but we still included that in the data. Next slide, please. Other complications, urinary retention, blood in the bowel, admissions due to hematuria, admissions due to pain. I think as expected, there was more blood in the bowel from the transrectal biopsies because that was the mechanism of through which the biopsy is taken. It's interesting there was some blood in bowel movements even with transperineal biopsies, which is unusual. Urine retention has often been a problem aimed at LATP. Actually, I think it's more aimed at general anesthetic transperineal biopsies, but there's nevertheless a slightly higher rate of urine retention in people who had an LATP. Next slide, please. Actually, would you mind just going back to the slide before? Because I think I just wanted to pick out one other thing. The thing at the top, reported biopsy to be painful or embarrassing. I think that's actually one of the key areas that has been and comes to light in the health economics as well, in that transperineal biopsy, this is men, middle-aged men, they felt much more exposed in having a transperineal prostate biopsy than a transrectal biopsy. For a transrectal biopsy, the patient is lying on his side, facing away from the clinician doing the biopsy. With an LATP, the patient is on his back with his legs up in lithotomy, and I think men realized that this was not necessarily the position they wanted to find themselves in, and found it much more embarrassing and probably a little bit more uncomfortable as well. So these are aspects that filter into a lot of the health economic analysis, and also some of the questions we have to ask ourselves about whether this is what are the priorities of patients when they're having their biopsies. I think we generally feel, obviously, cancer diagnosis is the priority, but there are a lot of secondary outcomes which are important to consider when thinking about what the best way to do it is. Next slide, please. So this is unpublished data for health economics, but it has been presented at meetings, and we're hopeful that will be a more complete paper will be available soon. The health economics are interesting because, again, this study was really to try and help with national guidelines, both in the UK and around Europe and America. There is no doubt that an LATP is more expensive than a transrectal biopsy. It's £149 more on average because of the bits of kit that we use to do it. It takes longer, can do less cases in the morning. And then the other element is the QALYs, and this is a the Oxford Health Economics group are a world famous health economics group, so it's based on a lot, and there is just a slightly worse outcome for men with LATP than with truss. So overall, after four months, actually there was it was very much the case that LATP was not as cost effective as a truss biopsy. And you can see from that graph where all the dots are, it puts it firmly in the truss arm being the more effective cost effectiveness, both in terms of QALYs and any other measure you wanted to use in terms of health economics. Next slide, please. So Translate's finished and published in and there's one of the final slides will show a kind of summary of the paper, but the conclusion was that LATP had a greater detection of grade group 2 and above prostate cancer. Actually, interestingly, as you got into the higher risk prostate cancer, the difference became much less and became no difference. There were fewer infection-related complications. Men did find it a bit more uncomfortable and embarrassing, but there were less problems beyond 7 days. Factors to take into account is that biopsy LATP does take longer. So in a busy healthcare system, when you could perhaps biopsy 8 men in a 4-hour session as opposed to 5 men in a 4-hour session, that does make a big difference to waiting lists. And that has filtered into the cost effectiveness of it, which as well as some of the pain and embarrassment levels. But this data we're going to work through this data more and see where we come. But we need to be clear on this when we're legislating for national guidelines. And what overall I think we felt Translate provided was finally some proper high level evidence that we have looked at both. LATP is definitely here to stay, and it's quite likely that that's going to be the way things will go, but it does not overwhelmingly suggest that truss is out of the picture, and that there is definitely some role for it still, particularly in some difficult areas of the prostate to biopsy. I'm sorry Richard wasn't here to present that. He would have done it better because he's so familiar with the data. He's been through it. He's lived and breathed it for the last 20 months, and would have been able to give you more nuance. But I think you get the gist, and be very happy to take questions at the end, or put any questions in the Q&A box at the side, and we'll take those at the end. As with any RCT, there are many centres involved, and we were proud that actually it was dotted all over the country. Scotland, Wales and England were involved. All normal, busy NHS departments working hard to recruit patients, and it's a testament to local PIs and actually to the leadership of Richard and Alistair and Freddie to push it forward across the country. We're very proud of what we've managed to do. And then the next slide, please. And as a result, it was published in the Lancet within the last 3 months. This is a conclusion slide, which you'll be able to see when the slides are distributed afterwards, giving a kind of summary of it and a bit more granular detail of the things I've talked about today. Good. I will hand over to Sandy now for something completely different, talking about mapping prostate cancer and the things that Freddie talked about at the start.
Thank you, Tom. So hello, everyone. So I'm a postdoctoral researcher at the University of Oxford, and I'm really happy to share our ongoing work, which, as Freddie said, explore the interface between 3D imaging and spatial transcriptomics to better understand prostate cancer progression. Thank you. So prostate cancer is the most common cancer in men, but its progression is unpredictable. Indeed, some tumor grows slowly and remain indolent, while others become aggressive, spreading rapidly and forming metastases. Unfortunately, current clinical markers often fail to provide the clarity needed to distinguish between these cases, leading to both overtreatment and undertreatment. So the fundamental question is, what makes one cancer spread and become life-threatening, while another remain indolent and relatively harmless? Next, please. Yeah. So to address this, our research focuses on 2 critical aspects of prostate cancer biology: the tumor heterogeneity, the genetic and molecular diversity within a tumor, and its neighborhood or microenvironment, what we call also stroma. So to study this, we are using 2 cutting-edge technologies: spatial transcriptomics and 3D imaging. Next slide, please. So before diving into spatial transcriptomics, let me start with spatial omics in general. So traditionally, scientists have studied cells by extracting a molecule like RNA or proteins from tissue sample, mixing them all together and analyzing them. But this is a bit like taking a smoothie and trying to guess which fruits were in it. So we get a general idea, but we lose a lot of details. And to get more details, scientists then develop single-cell technologies. So instead of blending everything together, we can now see individual pieces of roots or cells. So this tells us which cells are present and what they are doing, but we still don't know where they are located in the tissue. And spatialomics solve this problem by preserving the tissue structure and allowing the study of its molecule. So it can be, for example, RNA with spatial transcriptomics, protein with spatial proteomics, or even metabolites with metabolomics. So we now see where each cell is located in the tissue. And this is really important when we are studying a disease like cancer, where different parts of the tumor can behave in completely different ways. Some area might be more aggressive, while others may respond better to treatment. Next slide. So we have recently published a review on this topic, discussing the potential and the clinical implication of spatialomics in general. So you can scan the QR code here if you want to have a look. And there is also a useful table in the paper that provides an overview of the different spatialomics platform and methods. Next slide, please. So our goal is to unpack the tumor heterogeneity within the prostate and identify the origin of aggressive extraprostatic disease. So we want to identify the clones responsible for spread, treatment resistance, and in some cases, death from prostate cancer. Next, please. So, of course, it's important to remember that the prostate doesn't exist in isolation. It's surrounded by vessels, lymphatics, and bones that are responsible for keeping the prostate healthy, but also, of course, serves as pathway for spread. So the key question is, which part of the tumor is actually spreading? Is it the positive surgical margin here in blue, or this intermediate grade region in yellow, or maybe it's just the small but high-grade focus in orange? So to unpack this, we are using spatial transcriptomics. Next slide, please. So this technology has completely changed how we understand cancer. It allows us to map tumor in tiny regions of the tissue in incredible details, like 10 to 15 cells, what we call also spots. And each spot is like a pixel in a high-resolution image. So we have used this technology on prostate and lymph node metastasis. And from this, we get a detailed map showing which genes are active and where they are located. But we also have an idea of the DNA changes, like copy number gain or losses. And what makes this powerful is that we can use this map to group spots into clones and even build a kind of family tree that shows how the cancer has evolved according to these DNA changes. And this helps identify the clone that has spread to the lymph node, which is likely driving aggressive behavior. So let me show you one of our cases as an example. Next slide. Thank you. So here you can see, so on the left, the prostate tissue, and on the right, the lymph node metastasis tissue. So each little square represents the capture area of the spatial transcriptomics slide. And for each square, you have the histology annotation, mean the annotation of different cell type and tumor grade, and the clone we have identified. So what is fascinating is that we found multiple clones, including some that managed to spread to the lymph node. And when we trace this clone journey using our phylogenetic tree, we saw that it starts, if you follow the color, and Mariana, if you can just do next. So yes, thank you. Go back there. So when we trace this clone journey using our phylogenetic tree, we saw that it starts from the apex of the prostate, move through the middle zone, and then made its way to the base and seminar vesicle before finally spreading to the lymph node. So we are now digging deeper to figure out why this clone were able to spread and not the other one, what makes this clone different in terms of gene expression. And we are analyzing data from 10 patients to see if they have common features. Next slide, please. So we are also investigating the trauma around, so the microenvironment around each distinct tumor clone. And the question is, can we identify the contribution made by the stroma, for example, immune cellular neighborhood, to drive indolent versus aggressive behavior? So we are doing different analyzing, including analyzing the stroma in close proximity with the tumor and further away, investigating cell-cell communication and spatial human profiling. We are also upgrading some tissue to Visium HD, which offers super high resolution, a single cell view. And in addition, we are doing also multiplex imaging. Next slide, please. So I'm not going into too much detail about this, but for example, we find that the stroma around the earliest tumor clone, so as you can see, the blue one, so the ancestor one, is highly inflammatory, almost like the body was sending out an alarm reacting to the presence of the tumor. But as the tumor spread, the stroma around those later clones, so the one which is able to spread, it's much more supportive, helping the tumor grow. You can clearly see, if you look at the top panel, at the violin plot, you can clearly see with T cell and myeloid cells a clear negative trend as you progress through the clone tree. And same for the bottom part, you can see that CD4, CD8, so T cells, human cells, are more present in the microenvironment around the early clone than the spreading one. Next. So we are learning a lot from spatial transcriptomics and spatialomics in general, mapping gene expression and understanding how cancer progress and spread. So this gives us a solid starting point to identify what makes cancer aggressive, but gene expression alone doesn't give us the full picture. So to really dig deeper, we are adding another layer with advanced 3D imaging techniques like OTLS, open top light sheet microscopy, to look at the protein level. So think of it like reading a map. You can see the features, but to understand how they are connected, you need to step back and see the whole landscape. Next slide, please. Yeah. So of course you might ask, why not just stick to 2D imaging? And you're right to wonder, after all, for a long time 2D imaging has been the standard, and it's part of the reason we have well-established grading system, like the Gleason grading system for prostate cancer. Pathologists are trained in reading these 2D images, and it's easy to compare samples from past and present to track cancer progression. However, 2D imaging gives only a thin slide of a tissue, leaving out the full architecture. This is where 3D imaging makes a difference. So by looking at the tissue in 3 dimensions, we can quantify the shape of cells and see how they fit into a larger tissue structure. So this gives us a much more detailed view of the tumor and its microenvironment, making it easier to detect things that might not be visible in 2D, like hidden cluster of cells or early sign of metastasis. Next slide, please. So to illustrate what I'm saying, let's talk about blood vessel and glands, so convoluted structures. So when we look at them in a 2D slide, some glands might look poorly formed or irregular, but when we view them in 3D, we might find that they are actually well formed. And this is important because the current Gleason grading system, which guides prostate cancer treatment, is based entirely on glandular architecture. And as I said, there are also other aspects of the tumor where 3D imaging makes a huge difference. So the interaction with the tumor microenvironment, complex distribution, and small cell population. Next slide, please. So this is a concrete example to show the difference between 2D and 3D. In that example, pathologists look at the same tissue at different depths, mean they examine the tissue at different layers, and depending on where they looked, they assign different grades. And it's not a small difference. It can range from a GG1, 3+3, so a low risk, which leads to an active surveillance, no treatment, to a GG2, so 3+4, an intermediate risk, which might lead to a surgery. However, when these pathologists examined the entire 3D sample, they both agreed that it was a low risk, 3+3, active surveillance, no treatment. And then say that when they reported before a 3+4, it was eventually due to the way the tissue was cut. Next slide, please. Therefore, by analyzing larger tissue in 3D and as reported in this paper, it may improve the accuracy of prediction and decrease differences in risk assessment. So this highlight how important it is to consider the complex structure of tissue when making clinical evaluation. Next slide, please. So we have to move beyond 2D snapshots and develop high-resolution, in-depth 3D imaging to capture the full architecture of the tumor. That's why we are developing in Oxford a 3D imaging platform integrating multiplex imaging, visualization, and analyzing using machine learning and AI to map the tumor complexity. So our primary focus is prostate cancer, but we want this platform to be adaptable, and we are already testing this approach on other tissue types, such as kidney and bone marrow as well. Next slide. So everything I show you today highlight the power of spatialomics and advanced imaging, but all these techniques, even if they are groundbreaking, are not enough on their own. So we want to go even further. Next slide, please. Thank you. So in short midterm, our goal is to integrate spatialomics data into the 3D framework, aiming to bridge the gap between molecular and structural analysis. So by combining these techniques, each one complements the other, allowing us to refine molecular biomarker and, most importantly, gain a much deeper understanding of the tumor biology, how it behaves, how it spreads, and how we can better target it for improved clinical outcomes. Next slide, please. So I would like to thank all the people involved in this different project in UK and abroad, our generous funders, and obviously you for your attention.
Thank you, Sandy. It's fantastic cutting edge science, which is always fascinating to see. Now I'm going to talk again, and I'm sorry if it's me talking a bit, but this is my bit properly. So the PART trial is something that some of you may be familiar with. So this is a study that we've been running in some form or another for a number of years in Oxford, looking at, as Freddie discussed, are there techniques that we can reduce the side effects of treatment for prostate cancer? And the PART trial was designed to look at partial ablation, so focal therapy, versus radical treatment for the treatment of intermediate risk localized prostate cancer. Next slide, please. Probably we should have said this right at the start for those who don't know. The main treatment options for prostate cancer are traditionally either surgery in the form of a radical prostatectomy, often done robotically nowadays, or external beam radiotherapy, where the prostate is targeted from with ionizing radiation from the outside, or brachytherapy, where radioactive seeds are placed within the prostate to treat the whole prostate. We are talking about intermediate risk prostate cancer, which is this Gleason 7 area patients with Gleason pattern 3 and pattern 4, grade group 2 and 3. Now, next slide, please. There are some men, I think there's probably a slide missing there, but there are some men for whom they only have a localized or focal area of prostate cancer within the prostate, found on the various techniques that we've discussed already, particularly TP biopsy, in combination with a pre-biopsy MRI, where we see a focus of significant prostate cancer in one part of the prostate. And as the diagnostic pathway has become better and better, mostly around fantastic MRI and all the research that we've done on that, again, UK-led studies mostly from London, we are now aware that there's probably a group of men between 10 and 40% from the PROTECT data that are eligible for focal therapy, so just treating that part of the prostate. And as a result, 3 or 4 or 5 different technologies have been developed or been pivoted to being able to use this. So high intensity focused ultrasound uses ultrasound, which is focused a little bit like a magnifying glass focuses sunlight. It focuses the ultrasound to create a point of heat within the prostate that can destroy the tissue. Irreversible electroporation, IRE, or nanoknife as it's sometimes known, uses as it describes, effectively electricity, but the mechanism of electricity affecting cells to destroy the cells, cryotherapy, freezing the cells, or drugs delivered intravenously that then are activated using lasers of some sort, so vascular targeted photodynamic therapy being one of them, VTP. And the principle of focal therapy is that by not treating the whole prostate, we reduce the side effects significantly. So by treating the whole prostate, the main side effects include affecting the urinary function, so incontinence or irritation to the bladder, and it can affect potency, so causing erectile dysfunction as the nerves that supply the erections run either side of the prostate. So by just treating one part of the prostate, we're minimizing the damage to both the water pipe and the bladder, as well as the nerves either side of the prostate, thus minimizing side effects. But obviously, there's always a trade-off, and that trade-off is, does that compromise cancer outcomes? Next slide, please. So focal therapy has been around for quite a while, and Hashim Ahmed and Mark Emberton's groups have collected data in large databases, so not in a clinical trial per se, but a prospective collection of data. And in 2022, they published this paper of over 1,300 men who'd had focal therapy in varying forms. It was quite a heterogeneous group, but over many centres over 15 years, mostly with intermediate risk, some men with high risk disease, and certainly plenty of follow-up. Next slide, please. And the conclusion was from this this data that cancer-free survival, or failure-free survival, as it's called, so not needing to go on to a secondary treatment, so no evidence requiring salvage or systemic therapy, and no development of metastatic disease, was comparable to some of the other treatment modalities. So at 7 years, at intermediate risk, there was a 68% chance of still having had no further treatment in the intermediate risk patients, and indeed at 7 years there was 100% metastatic free survival rate, which is quite high, obviously quite high. Overall, 1 in 5 men, so about 20% of men, went on to have a second focal treatment, which I think is an interesting stat. But the conclusion was that focal HIFU in particular was well tolerated, with good cancer control in the medium term. Next slide, please. And other data set have been published by the same, mostly with the same group from a similar data set, suggesting that the type of focal therapy used does not make a big difference, and that focal therapy versus radical prostatectomy and other factors are no clinically relevant differences between those. However, all this data is not within a proper randomized trial. Next slide, please. Currently, focal therapy, using HIFU in particular, is available in the NHS, but with special arrangements. As you can see from recommendation 1.1, the national guidelines still feel that there's limited evidence, and therefore this procedure should only be done within special arrangements for clinical governance, or in a trial, or in an audit, an organised audit. Next slide, please. And again, the European guidelines have changed a little, probably under some pressure from people around the world who feel focal therapy has a way forward. 2022, focal therapy should only be delivered within a clinical trial or a well-designed prospective cohort setting. By 2023, that had been modified a little, that it should be within a prospective registry, and that's where the data for those big those data sets from London have come from. Registries, both the HEAT registry for HIFU, and there's I can't remember. There's a cryotherapy registry as well. So other than HIFU and cryo, there are no studies that are of sufficient power to enter the guidelines. So all other ablative modalities should only be offered within well-designed prospective trials. Next slide, please. So with this in mind, Freddie and I, Richard, the UCLH team led with Mark Emberton and now Imperial Hashim Ahmed have over the time sat down and talked about trials, and we in Oxford we kind of took the bull by the horns and thought, right, let's get on and do it, because nobody was trying. And with the Protect data group, but with the Protect team's experience, we felt we could run these trials. So the aim was to assess focal therapy in the context of clinically significant disease. So we're not talking about men with low risk disease. We always have wanted it to be pragmatic, because the diagnostic pathway, particularly when we were first setting up, was changing a lot. The country was moving towards pre-biopsy MRI. Even now, there's still questions around what the best biopsy modality is. And that continues to change. So we were trying to trying to move with the times as we were moving the trial forward. And with the Protect team's experience of large multi-center trials, we felt we could do it, and in particular embedding QRI, so detailed analysis of how doctors were recruiting patients into these trials, doctors and nurses, importantly, recruiting patients into these trials. And I'll talk about that a little bit more in a moment. Next slide, please. So throughout, so we've been running this for a little while. The aim was to look at partial ablation versus all radical treatments. The initial feasibility study that we did probably 10 years ago now, started at 10 years ago, was actually just against surgery. But the aim was to randomize these two groups, to have the quintet recruitment intervention embedded in the system, and to try and recruit, well, up to 800 men in two arms over many centres around the country. Next slide, please. And as you'll see, over time, we've had several places involved. Yeah, thank you. And it's got bigger and bigger. So places that are open to recruitment at the moment are, again, from Scotland in the north, Edinburgh in the north, down to Kent in the south. Several of us in the Thames Valley, but also London, London, Coventry, Leeds, and areas like Cardiff and Liverpool and Sheffield are looking hard at it still at the moment. Next slide, please. The feasibility study, which we reported on just pre-COVID 2018, showed that we could do it. With the support of the NIHR, we managed to, this was looking to recruit about only about 80 men, but it was important to prove that men were prepared to be randomized between a focal treatment and a radical treatment for their prostate cancer. It's a difficult decision. It's difficult hearing about prostate cancer when you've been diagnosed in the first place. It's then even more difficult because we as clinicians present them with multiple options as to what the right treatment is, and then to bring in the context of randomization and some element of risk as to whether they get the choice of the treatment they want becomes a complex procedure. The quintet recruitment intervention, so QRI, allowed us to change our recruitment rate from 1.4 patients a month to 3.9 patients a month, and it was fascinating. I was I learned so much from it. The keys to recruiting patients into randomized trials is very skillful and requires professional advice to get the maximum recruitment that you can. Things like having equipoise, methods of describing a trial, nursing support, giving patients time to understand what they're letting themselves into, letting them understand that all the options are correct, none of them are wrong, were key parts to enabling us to improve our recruitment. And as a result of the successful feasibility study, i.e. we proved we could recruit people into a quite a complex surgical trial, we successfully were able to get started on the main trial. Next slide, please. So the main trial, the things that we changed was we brought in all radical therapy modalities, so radiotherapy, brachytherapy. We've added in one or two other, we added in an IRE, nanoknife, as an option for the focal therapy. And again, we were asking the questions, what's the trade-off between side effects and cancer control? Next slide, please. The primary outcome is treatment failure, which I kind of defined at the start, which is patients having to go on to alternative treatments. So after partial ablation, needing whole gland treatment, either radical prostatectomy or radiotherapy, and after radical therapy, needing to go on to have a second line treatment. So after surgery, maybe radical radiotherapy, or after surgery, hormone therapy, or indeed chemotherapy. And again, importantly, as with the Translate study, health-related questionnaires, health economics, adverse events, disease progression, and also continually analysing the diagnostic pathway. Next slide, please. HIFU is the mainstay of the treatment. For those of you who aren't aware, there are probably two different companies who produce focal HIFU machines. One is called is from Sonoblate. The other is from EDAP. The majority of cases in the UK use the Sonoblate machine. The focal one from EDAP is being used in Edinburgh, and that's the first time it's been used in the UK, and it's been proven to be very effective so far. So the trial is not aimed to assess these two technologies against each other, but we will have some information regarding that. Next slide, please. IRE, nanoknife. I think I saw that Mark Laniardo was on the talk here. Nanoknife is an exciting technology to treat particularly anterior lesions within the prostate. It is fast coming up on the tracks as one of the best modalities for focal treatment, and we've been very pleased to be able to combine with AngioDynamics, the company that produces it. They've supported us hugely to enable centres who weren't previously able to access this to be part of it within the trial, and has broadened the number of patients who are eligible for focal, because it can reach tumours that HIFU can't. So that's been a really exciting addition to the PART trial. Next slide, please. I think I'm not going to go through in detail the trial's design, but in principle, men who have either a single dominant nodule or a single area of clinically significant prostate cancer with insignificant prostate cancer elsewhere are eligible, and they're randomized to partial ablation or radical treatment. Next slide, please. And then they're followed up rigorously over time with PSAs, health questionnaires, MRI after year, further biopsies after year, and then at 3 years as well. Next slide, please. Next slide, please. So I'll just go back one. So, I mean, in conclusion, the PART trial, and we haven't got any data on this part of the PART trial because we're still recruiting. We've recruited about 100 men into the main trial. The NIHR have been very supportive. When we were getting it started, it was all through COVID, which completely put a halt on all clinical trials and any progress. And Richard Bryant in particular, with Freddie's able support, has pushed it very hard to get the momentum going again, to a point now where I think the end is in sight. We are going to be able to complete the study over the next 2 or 3 years with a slightly amended recruitment target of around 400 men. And I think this is going to be another key set of data that's going to influence guidelines for the long term, because there's no doubt, I think, that there are a group of men for whom focal therapy is appropriate, but we need to be very clear who it is, who should be doing it, and in what circumstances the right time to do it is, and what the programme around it should involve. And I think, again, we feel strongly here in Oxford and the UK, London, our UCL and Imperial colleagues should take a lot of the credit as well. We're driving appropriate use of this by using research to innovate and make sure we're producing the right data. So on that note, I'm going to stop on partial ablation and focal therapy and hand over to Aaron to talk a bit more about radical prostatectomy.
Lovely. Thanks, Tom. Thanks. It's lovely to be here and join you all. And I just want to quickly thank Mariana for organising this and getting this all here today, and the many emails and few meetings we've had. So thank you, Mariana, and thank you, Ferdinand, for making the tech run so very well today. Thank you. So as Tom said, I'm going to talk to you a little bit about some studies, or a study we're running looking at how we can improve radical prostatectomy, and in particular image guided fluorescent surgery. So next slide, please. So we are living currently in an era of precision cancer medicine, and probably have been so for the last decade. So we are increasingly using chemotherapy drugs, immunotherapy drugs that are tailored to the genetic signatures of an individual's cancer. And similarly, radiotherapeutic technologies have become more eloquent. Particle therapies, proton beams, and magnetic resonance linear accelerators are all coming to the fore. And of course, robot-assisted surgery has been around a while now, and has revolutionized this particular operation, radical prostatectomy. And each generation of robots is becoming more and more sophisticated and improving the techniques for surgery for us. And similarly, if you just fast forward, Mariana, just to the next little animation, yeah. And similarly, molecular imaging has emerged as a technology to help us diagnose, locate, and accurately stage cancer. So here's an example of a PET scan. Next slide, please. So in prostate cancer, there is certainly an unmet need in surgery for more precision. And we find that a third or more of our patients have high stage disease than expected. So the preoperative staging may tell us that the cancer is completely confined to the prostate, and actually once the prostate specimen is out, we find that it's breached the capsule of the prostate and is by definition locally advanced. And that does have some implications for how we approach the surgery, and also the outcomes for the patients in terms of oncological outcomes and their cancer recurrence rates and things like that. And we do find that this surgery is associated with a positive surgical margin rates, be anywhere between sort of 15 to 50%, depending on the stage of cancer. So a question that the team in Oxford and Freddie in particular wondered at the genesis of this project is can we use imaging techniques to improve margin rates and outcomes? And Mariana, can you just play the little film there? Thank you. So here's an example of a nerve sparing being performed on a prostate. So on the right hand side is the prostate, and the structure on the left is a neurovascular bundle that's being gently dissected off the prostate in a very precise way. But you can imagine it's quite vulnerable to leaving a positive surgical margin there. So we're wondering if we can use modern fluorescent techniques to help guide the surgery. Next slide, please. So Freddie collaborated with Boris Vonjevic, who's a professor of biophysics in Oxford, and his background is in physics and engineering, and he has particular expertise in optical systems looking at fluorescence in biological tissues. And they were wondering, could they develop a system to look at fluorescence in prostate cancer? Well, problem is you can't just use a fluorophore or a dye alone. That's not tissue specific. So the challenge is to find a way of targeting tissues so that the fluorophore will fluoresce only the cancer and not normal tissue. And also a way to use the imaging where you can see both all of the anatomy as well as the glowing tumor. Can you fast forward to the next slide, please? So here's an example of what the fingertip looks like under white lights, and then the fluorescence of the drug that we use, and I'll come to that shortly, in the middle, and then an overlay on the right hand side that you can see there. So an optical system where you can see the normal anatomy under white light and the fluorescence under our special platform and combined so that you can see everything in context. And just click on again and show the bottom. So Boris initially used his platform in endometrial cancer for sentinel nodes, and it seemed to work reasonably well. And next slide, please. So the challenge then came, how can we target prostate cancer with a fluorophore? And the answer is PSMA. So that stands for prostate-specific membrane antigen. So this is a protein that's preferentially expressed, or selectively expressed, shall I say, on the surface of the large majority of prostate cancer cells, and it's upregulated in the vast majority of prostate cancers. And a mini-body was made available by a company called Imaginab. A mini-body is an engineered fragment of an antibody, so it's much smaller than an antibody, and has high specificity for its target. And the low molecular weight means it's very suitable for tissue penetration and clearance through, the kidneys or the liver is very high. So it's very amenable to use as a drug. So they managed to combine the mini body with a dye, with a fluorophore, and the initial studies were in mice. Yeah. So here's an example of a fluorescent tumor that's going to be, there you go. So this is a mouse with a xenograft. So these are human cancer cell lines that have been implanted into the mouse. And this cell line does, like most cancer cells, express PSMA, and you can see it's fluorescent. On the left-hand side of the mouse, there is a non-PSMA expressing tumor that doesn't fluoresce. There you go, and you can see a little bit of tumor that's left behind. So that's the principle. So we want to reduce our margin rates by being able to identify a fluorescent bit of tissue that's not been taken out with the initial resection. So we can go back and remove that. Okay, next slide, please. Perfect. So the first, these studies in mice were done now 11 years ago, almost to the day. So that's 14th of May. There we go. And so that showed in principle that this technology works in a surgical setting. And actually, only just over 4 years later, the technology was used in the first human patient, so pictured here, that Freddie operated on back in July 2018. Okay, next slide, please. So the next is, who are we looking at offering this technology to in the trial? And the short answer is the patients who are most risk of a positive surgical margin. So these are patients with higher grade disease, bulky tumors that we would know are already breaching the capsule of the prostate or even going into the seminal vesicles. So these are the patients that we know before the surgery have the highest risk of having a positive margin. So these are currently the patients we are recruiting to the trial as much as possible. Next slide, please. And again, next slide, please. So here's an example of a positive lymph node being identified during surgery. Here we go. So you can see the large lymph node there, and under fluorescence it glows very avidly. So there's, or not, and histologically that lymph node can contain cancer, and it's examined by a pathologist. So that's a very good example of seeing disease outside of the prostate that otherwise one may miss. And the video on the right hand side, just if you play that. So this is an example of a dissection of a left neurovascular bundle off the prostate. So the prostate, you can see there on the right hand side, is very avid. The neurovascular bundle is sort of tenting diagonally from the top right to onto the bottom left, and you can see a small area of glowing fluorescence on that neurovascular bundle, which pertains to what would have been a positive margin had it not been detected. So this allows us to identify an area of cancer that's been left on the neurovascular bundle and then can be taken off separately as a separate specimen to ensure complete excision of the tumour. So you can see that we are now locating it with our instruments and are able to remove it. There you go. Perfect. All right, so, and if you just show the bottom film for us. So this is an example of a negative. So this is less exciting because you won't see anything. So what you'll see on the left-hand side is a very avid prostate that's been separated from the neurovascular bundle on the right-hand side. And you can see the neurovascular bundle is not glowing. So in this situation, there's no evidence of any disease that's been left behind to be confident that a nerve spare has been done without compromising the oncological outcome in this case. Okay, next slide, please. So it's a big study in the sense of it sounds like it's quite straightforward. You give a patient a drug and you operate on them a few days later. In reality, it requires a huge team of people to get involved. Ian Tulis, who is in the top picture on the right-hand corner with the check shirt on, comes to all of our theatre lists. So he's a background in mechanical engineering and worked very hard with Boris to develop and build the optical platform that we use, so the scope that we use, and he comes to every list, makes the measurements of fluorescence and does his wizardry. And then there are a bunch of surgeons who have been doing this surgery over the course of the study. So Alistair was involved in the study, and Tom and myself are currently doing it. And Tom only last week was operating on 2 patients who are in the trial. And then there are a lot of people involved in the pathology side of things and in the labs looking at the tissue once it's been removed to look at the genetic profiles of the patients who've had tissue taken from this study. Okay, next, please. And then finally, again, even beyond the people involved in the study formally, there's a huge group of people involved in theatres, a bunch of scrub nurses, runners, anaesthetists, and then of course surgeons and Freddie comes to almost every case to this. So the theatre is often quite crowded because everybody's very interested and excited to see what's going on. Next slide, please. And then you may or may not have seen, it caused a little bit of a buzz last year when the feasibility data was published April last year. And slightly unexpectedly, it caught hold in the media, and for a while, next slide, please. For a while, Freddie was in great demand with lots of media requests and interviews on BBC Breakfast and whatnot, and much of the study was profiled in the press, so generated a lot of interest and contact to us from patients who'd seen this in the news. So it's obviously struck a chord with members of the public because it's quite exciting a topic to see. Next slide, please. And then finally, just thank the people involved in the study that I've not directly mentioned already, and the people at ImagineAb who have developed the drug that we use and have made it available to us, and of course the steering committee, and most importantly the patients to whom we are very grateful and always amazed that they participate in all of these studies, and actually without them none of this stuff can be done, and we're very grateful because largely they don't do it for their own benefit, they're doing it for the benefit of future patients, and that's very commendable and admirable. And that's everything on what I have to show.
So hopefully everybody's found that useful. A whistle-stop tour of the program that we've been running here in Oxford and around the Thames Valley and around the UK for the last 10-15 years and longer, and hopefully that's giving a flavour of what the trials involve, and as Freddie introduced at the start, that's just almost the tip of the iceberg. So Mariana, I think you're going to the slides are going to be sent out. How are you going to distribute the slides again after this?
Yes, absolutely. Well, first, Tom, thank you very much for nice welcome, and thank you. Yes, so the slides will be distributed together with the link to the webinar recording after the event. Just give us a couple of days to upload everything and make it look very nice. So everyone will receive, those who were not able to join us today because it is quite busy clinical time for many. So they will also receive the recording and slide deck.
Brilliant. Thank you. To thank Aaron and there may be something that's appeared. Yes, Aaron and Freddie and Sandy in particular for joining us clinicians and giving a proper scientific talk while we just talked around clinical things. For getting involved and joining us for this webinar. And I think at that point, Marianne, if you're happy, I think we might call it a day.